Welcome, my friends, to a place where medicine and wonder meet. I'm Dr. Haitham Mekawi, and today we open the doors to the magical world of pediatric anesthesia. Here, every breath is precious, every heartbeat a story waiting to be protected. In this room of gentle lights and careful hands, science becomes kindness, and technology learns compassion. Together, we'll journey through this art, learning how to guide our smallest patients safely through sleep and back into light. So take a deep breath, let your curiosity rise, and step with me into a world where caring becomes an act of creation. Here's our roadmap for today's journey. First, how children differ from adults in their airways, lungs, hearts, and metabolism. Second, how to prepare the child and family safely, including modern fasting rules that keep kids calm and hydrated. Third, how to guide gentle induction and secure a small airway with precision and backup plans. Finally, how to maintain anesthesia, protect warmth and fluids, control pain, and bring our patient back smoothly to smiles and light. Children are not small adults. They are entirely different biological worlds. Their metabolism runs faster, their hearts beat quicker, and their lungs trade oxygen with breathtaking efficiency. A newborn breathes nearly 40 times per minute compared to an adult's 12. Their oxygen consumption is twice as high, and their functional residual capacity is smaller, meaning they desaturate fast when apnea occurs. The airway is smaller and softer. A few millimeters of swelling can halve its diameter and multiply resistance 16-fold. The heart depends almost entirely on rate, not strength. A slow heart rate quickly means a falling cardiac output. Their thermoregulation is immature, their skin thin, and their response to stress amplified. Understanding these differences is not just knowledge, it's survival. Every dose, every breath, every second counts when you care for the smallest patients. Let's take a journey inside the airway, the pathway of life, and the anesthetist's most sacred responsibility. In children, the airway is softer, smaller, and more anterior. The tongue is proportionally large, the occiput prominent, and the epiglottis is long and floppy, often omega-shaped. The larynx sits higher around C3 to C4, compared with C5 to C6 in adults. The narrowest point in the pediatric airway is the cricoid ring, a complete cartilage that forms a natural cuff. Because of this, a small amount of swelling or pressure can cause major obstruction. Airway resistance increases exponentially. Remember Poiseuille's law. Resistance rises with the inverse of the fourth power of the radius. A 1 mm decrease can double or triple the resistance. For positioning, neonates need a small shoulder roll to align the oral, pharyngeal, and laryngeal axes, while older children achieve this naturally. The golden rule is gentleness. Never force the airway. Never rush the intubation. Every pediatric airway should be approached like a fragile instrument, tuned carefully and handled with respect. Now let's talk about the little heart that never rests, the pediatric heart. In children, cardiac output depends almost entirely on heart rate. Their ventricles are small and non-compliant, so they cannot increase stroke volume the way adults do. When the heart rate falls, even slightly, cardiac output and blood pressure drop dramatically. That's why bradycardia in a child is not a rhythm, it's a warning. The most common cause, hypoxia. Always give oxygen first, then atropine if the heart doesn't respond, 0.02 milligrams/kg, minimum dose 0.1 milligrams. Tachycardia, on the other hand, is usually a compensatory sign, a clue that the child is anxious, hypovolemic, or too light under anesthesia. Every monitor beep tells a story. Our job is to listen and act before that story turns silent. Children lose heat much faster than adults, and under anesthesia, they can't defend themselves. With their large surface area and thin skin, they radiate warmth like tiny suns fading in the cold air of the operating room. Heat loss happens through four main pathways: radiation to cool surroundings, convection from air movement, conduction to cold metal surfaces, and evaporation from skin prep and open wounds. The result is hypothermia, silent but dangerous. It increases oxygen demand, delays drug metabolism, prolongs recovery, and in neonates, can even lead to acidosis and apnea. Prevention is our best therapy. Pre-warm the room before the patient arrives. Cover as much skin as possible. Use forced air warmers, heated IV fluids, and radiant lamps. Keep the thermometer connected. Measure continuously, not occasionally. In pediatric anesthesia, warmth equals safety. Every degree we save is a victory. The fasting rule is one of the simplest and most misunderstood parts of pediatric anesthesia. We call it the 1-4-6 rule, easy to remember, vital to follow. 1 hour for clear fluids like water, apple juice, or oral rehydration solution. These empty from the stomach quickly and keep the child calm, hydrated, and cooperative. 4 hours for breast milk, nature's perfect nutrition but rich in fat, so it stays longer in the stomach. 6 hours for formula or solid food, including cow's milk. Longer if the meal was heavy or fatty. The goal is balance, enough time to clear the stomach, not enough to cause dehydration, irritability, or hypoglycemia. And remember, if it's an emergency or the child has reflux, bowel obstruction, or delayed gastric emptying, always treat it as a full stomach and plan a rapid sequence induction. Proper fasting isn't punishment, it's protection, designed to keep little lungs safe and little hearts beating strong. Induction is where the story begins, the moment between fear and trust, between wakefulness and sleep. For children, the goal is calmness, connection, and safety. We use 2 main routes. Inhalational induction with sevolurin, smooth, sweet-smelling, and ideal for those without IV access. It lets the child drift to sleep peacefully while holding a favorite toy or parent's hand. Intravenous induction with propofol or thiopentone is faster and preferred when IV access is ready, especially in older children or emergencies. Always pre-oxygenate with gentle reassurance, not with force. Explain to the parents, make eye contact with the child, and turn anxiety into curiosity. Remember, induction is not just pharmacology, it's choreography. Every word, every gesture, every breath should make the child feel that sleep is safe. Now we reach one of the defining moments of anesthesia, securing the airway. It's a skill that blends art, anatomy, and anticipation. In children, intubation requires preparation more than strength. The tube is smaller, the glottis higher, and the margin for error narrower. Before you start, make sure equipment is checked and sized correctly. Endotracheal tube equals sign AJA, 4 plus 3.5 for uncuffed, plus 0.5 for cuffed. Suction, mask, and backup devices are ready. Pre-oxygenation is gentle, not forced. During laryngoscopy, visualize the epiglottis, lift softly, and advance the tube only until the black mark passes the cords. Confirmation is the golden rule. Bilateral chest rise, mist in the tube, and a continuous capnography trace. If difficulty arises, remember the difficult airway society algorithm. Call for help, optimize position, use adjuncts, limit attempts, and maintain oxygenation. Every successful airway is not just a procedure, it's a partnership between vigilance, preparation, and calm leadership. Children are made of movement and water, and during anesthesia, it's our job to keep that ocean balanced. Fluid therapy in pediatrics is both mathematics and mindfulness. We calculate, but we also observe. The foundation is the 4-2-1 rule for maintenance. 4 milliliter per kilogram per hour for the first 10 kilograms, 2 milliliter per kilogram per hour for the next 10 kilograms, and 1 milliliter per kilogram per hour for every kilogram thereafter. Choose isotonic solutions, like plasma light or balanced crystalloids, to prevent hyponatremia. In neonates, add glucose 1 to 2% to avoid hypoglycemia. Replace ongoing losses from suction, bleeding, or evaporation. Estimate and restore carefully. And never forget monitoring. Urine output should stay above 1 milliliter per kilogram per hour. It's the quiet voice of the kidneys telling us perfusion is safe. The art of pediatric fluid therapy lies in balance. Not too much, not too little. Just enough to keep the tide of life steady. Pain relief is one of the greatest gifts of anesthesia, and in children, it requires patience, balance, and understanding. Pain in pediatrics is real, measurable, and deeply emotional. The child may not always describe it, but their body speaks. Faster heart rate, crying, grimacing, restlessness. The key is multimodal analgesia, combining small doses of different drugs and techniques to target pain from multiple directions. Use paracetamol 15 milligram per kilogram IV or rectal and ibuprofen 10 milligram per kilogram orally as first-line agents. Add fentanyl 1, 2 microgram per kilogram IV intraoperatively for short-lasting pain relief. Regional anesthesia is a cornerstone. Caudal block, ilioinguinal, TAP, or nerve blocks all reduce opioid need and hasten recovery. But beyond drugs, there is presence, a calm voice, gentle reassurance, and involving parents early. A child who wakes in peace heals faster. Remember, our goal isn't to silence pain, it's to restore serenity. In pediatric anesthesia, emergencies appear without warning, and how we respond defines safety. The most common crises we face are laryngospasm, bradycardia, and desaturation. Laryngospasm is the #1 enemy. It often begins silently, an inspiratory stridor, or falling oxygen saturation. Act fast. Stop the stimulus. Apply continuous positive pressure with 100% oxygen. Deepen anesthesia with sevoflurane or propofol, and if unresolved, give suxamethonium 0.5 milligram per kilogram. Bradycardia follows hypoxia. Always treat oxygen first, then atropine 0.02 milligram per kilogram, minimum 0.1 milligram if persistent. In any crisis, remember the golden rule: oxygen before everything else. Communication is your most powerful drug. Assign roles, speak clearly, and stay calm. Emergencies test not just your skill, but your composure. The calm voice in chaos saves lives. Recovery is where anesthesia truly proves its art. The safe awakening, the calm transition, the gentle return to the world. The child's first moments after surgery are sacred. They breathe anew, feel warmth again, and search for familiar faces. Extubate only when the airway reflexes are fully awake and breathing is steady. Provide oxygen, monitor saturation, and ensure normothermia. In the recovery room, comfort is the key. A parent's voice, a warm blanket, and a smile often work faster than any drug. Watch closely for airway obstruction, desaturation, or pain-related agitation. Reassure, reposition, and use gentle suction if needed. A smooth recovery isn't about speed, it's about stability and peace. It's when science ends and human connection begins. When the child wakes with a smile, our mission is complete. And so our journey ends where it truly begins, in the quiet heartbeat of a child who sleeps safely and wakes with a smile. Pediatric anesthesia is not just a discipline, it's a promise. A promise to blend knowledge with kindness, skill with empathy, and science with soul. We work in moments where trust is absolute, where families hand us their greatest treasure. Every dose, every breath, every heartbeat matters. Remember, prepare completely, act calmly, communicate clearly, always protect warmth, oxygen, and dignity. Because our mission is not merely to anesthetize, it's to preserve life, comfort, and hope. And that is the true promise of pediatric anesthesia. Thank you for your time, and please don't forget to like and share and subscribe.